Hello, everyone. Welcome to today's webcast, Shaping the Future for Duchenne Muscular Dystrophy, Collaborative Approach for Refining Care. My name is Laurent Servet. I'm Professor of Pediatric Neuromuscular Disease at the University of Oxford in the UK, and I'm very happy to be with you today. And so I'm very happy because we have a very, very great faculty, very diverse in terms of competency, in terms of origin. So first of all, I would like to welcome Jackie Russell, who is a nurse practitioner at Sydney Children's Hospital Network in Australia. We have Zoya Alashwani, who is a consultant pediatrician at Birmingham Hospital in the UK, and Sam Kearns, who is a pediatric neuropsychologist at the University Hospitals of Leuven in Belgium. And I would really like to extend a special welcome to Dovile Dovida Chute, who brings a unique perspective as the mother of a child living with Duchenne muscular dystrophy, and her firsthand experience and insights will undoubtedly enrich our discussion today. Our primary goal today is to ensure that each of you leave this session with a clear understanding of the learning objective you can see on the screen. We have structured our activity to cover a variety of topics essential to advancing care for Duchenne muscular dystrophy. In addition to informative discussions, we will feature role-playing clips showcasing examples of effective and ineffective approaches during clinical routine. This practical demonstration will provide valuable insight into best practice and common pitfalls encountered by inpatient care. Before we proceed, I want to acknowledge that this program has been made possible thanks to an educational grant from Pfizer. So your participation in the assessment questions is crucial to our understanding of the impact and effectiveness of this webcast. These questions will be presented both at the beginning and the end, allowing us to assess the efficacy of this webcast. So these are our disclosures. And now I think that we can go into the topic itself. Duchenne muscular dystrophy is a very severe condition. It's a muscle deteriorating disease, and it leads to rapid loss of mobility and loss of ambulation today in every kid where we make the diagnosis at different ages, actually, from 6 to 16, 17 years old. But unfortunately, today, all kids lose ambulation. And the estimated global prevalence is about 7 cases per 100,000 male. And there are different studies in different countries and different regions, but we can keep in mind that about 1 out of 5,000 newborn, male newborn, is affected by Duchenne muscular dystrophy. And the root cause of Duchenne muscular dystrophy is actually a mutation, most of time an out-of-frame mutation in the dystrophin gene. And because of the dystrophin gene, the cell is lacking a shock absorber, but a shock absorber with several functions, and it will be much more fragile, and it will destabilize the muscle fibers during movement. So we need to understand that the dystrophin gene is one of the biggest in humans, right? There are 79 parts that are read, and we call it exons, right? Because in a gene, you have parts that are read, we call them exon, and between them, there are introns. Dystrophin is simply a giant, 79 exons, and between these exons, the introns will be removed during a process that we call the splicing. So it's a rod-shaped protein, and the very first function of dystrophin is to provide a strong mechanical link between the muscle cytoskeleton and the extracellular matrix. So it binds with both parts, but on top of that, there are several binding sites on the dystrophin for interacting with key proteins in the muscle cells. Duchenne muscular dystrophy is not only a disease of muscles, it's also a disease of other organs at different time in life. And one probably of the most important is the brain. Cognitive and behavioral problems have been associated with Duchenne muscular dystrophy. They are different isoform of dystrophin. Some of them are expressed in the brain and some not. So there are mutations into the dystrophin genes that are more prone to be to generate a brain involvement. And we can keep in mind that the more distal is the mutation, the higher is the risk to have a central nervous system involvement. And this starts with mutations after exon 45. We can keep in mind that many kids with Duchenne muscular dystrophy, including those with mutations before exon 45, will have some kind of attention deficit, but it can go up to very severe cognitive issues and sometimes autistic features in patients with the most distal mutations. So we need to keep in mind that several types of mutations may happen in the dystrophin, and Duchenne results most of the time from out of frame. It means that you have no dystrophin that is produced. But these mutations can be deletions, which is a gap in the gene, duplication, which is the repeat of a structure, insertions or deletions of one or several pairs of base. You can also have a single pair of base that changes and that generates a codon that means stops. In general, patients with Duchenne express no or very few dystrophin. And then if this mutation does not affect the reading frame and that you can still express a little bit of dystrophin, you have a milder form that we call Becker muscular dystrophy. And you know, we've written milder with coma because actually it is clear that for some patients Becker is not mild at all. Becker patients in general express a low amount of truncated dystrophin. So these are different types of mutations. As you can see, we have zoomed on a very specific region, which is the region between exon 45 and 50. You can miss an exon, like exon 50. And if you miss exon 50, you have definitely an out-of-frame deletion, and you will have no protein. But you can also have a deletion that is slightly larger, like for instance, a deletion of 49 to of 50 and 51. And if you're missing 50, 51, there is no disruption of the reading frame. And the exon 49 and exon 52 can be, there is no disruption of the reading frame between these two exons. So you will get a mutation that respects the reading frame. You will have a truncated dystrophin, probably in a lower amount, and this is a typical mutation of a Becker muscular dystrophy. You may have also a duplication, and look, this is a duplication of exon 50, and as you can easily understand, this disrupts the reading frame. And then you can have more subtle mutations. So for instance, if a single pair of base is inserted or deleted, then you will disrupt the entire reading frame, and sooner or later a stop codon will happen. And then you may also have a very simple mutations that affect a single pair of base, and because of that, a mutation, a stop codon will happen, and there will be no reading of the RNA. Finally, you may also have some mutations that happens in the intron, and because of the intronic mutations, having abnormal splicing of this intron and the flanking exon during the splicing process. So because of the absence of dystrophin, there is a destabilization of the membrane, an increased calcium permeability, and several downstream mechanisms. And unfortunately, this will lead to the muscle cell death. Of course, this muscle cell will be replaced by the satellite cells that are around, but these satellite cells will have the same genetic mutations and will have the same fate. So there are some mutations in Duchenne that are associated with a slightly milder phenotype, but altogether the genotype-phenotype correlation in Duchenne is very weak. We have patients who are eligible for exon skipping 44, so which means the deletion that are flanking these exons may be slightly milder, but this is just exception, right? And in general, we say that out-of-frame mutations leads to Duchenne, in-frame mutation to Becker, but there are exceptions. For instance, if the deletion is so large that actually there is nothing remaining of dystrophin, or if it affects very specific domain. And again, maybe the most strongest genotype to phenotype correlation is the one that is associated with central nervous system issues in the most distant part of the dystrophin. And last and probably least, there are also patients with a very large mutations that not only encompass the dystrophin genes, but also the neighboring genes. Most of them are associated with intellectual disability. So dystrophin is located on the chromosome X, which means that the disease affects mostly the boys. There are some girls who can be affected. Sometimes we understand why, because they have, for instance, Turner syndrome. Sometimes we just don't. And the mutations can be inherited from mom. It's the case in about 50% of cases, right? And in 50% of cases, it's what we call a neomutations. And that very rare case in when the mother is what we call a mosaicism, which means that she has the mutations in the ovarian, but not in it cannot be found in the blood. So we, even if in ladies who are not carriers, we should be careful and propose diagnostic, interrodiagnostic in boys, for boys. So of course, the fact that the possibility of recurrence will drive our strategy to manage these families and to propose to try to decrease the risk of recurrence of Duchenne muscular dystrophy. And then comes the questions of the diagnostic and how we manage it, how it happens in several countries. And I think that Zoya Alashwani will be certainly the best person among us to explain us what is actually the journey of the diagnostic for Duchenne muscular dystrophy.
Talking about the diagnosis, and at the moment children will be tested for the condition if they present with symptoms. And if you look at different countries, and there are different points in time where data was collected, generally we remain at diagnosis between ages 4 and 5. Obviously, children, when you go back in the history, there are some symptoms that parents may have noticed in early childhood, and we have come across situations where families approached health professionals and they had some subtle worries, and then they asked multiple people before they got to a stage where testing happened. So there is a time lag, we noticed, between when the first concern started, first symptoms noted, and the time of diagnosis being made. And multiple professionals can be approached. So health visitor tends to be one that the parent may talk to, but they can present in any clinic. Some of the children might present with toe walking in an orthopedic clinic. Sometimes it's the physiotherapist who first saw them. And sometimes they even present to a neurologic. So any professional could come across these children. Just to summarize, different signs and symptoms that these patients can present with. And there is quite a lot of overlap with a lot of other neurodevelopmental or developmental disorders in general in early childhood. Motor delay is very common, but there are other things that parents might also report. And one of the common ones could be activities against gravity, so getting up from the floor, climbing stairs. However, remembering this might not be something immediately noticed at the beginning, in particular if the child has a neurodevelopmental delay, which is common, as we already mentioned, in Duchenne muscular dystrophy. Some of these signs may be put as a part of a global developmental delay as well. Occasionally, things can be, the children can just present with a speech delay to start with, and that might be the most marked thing. And we will come to that later, but there has been situations where liver transaminases was done for a different cause and was found to be raised. And then we realized this was from a muscle origin when CK was tested. So if you were to suspect that the child has delay and you're thinking, oh, I need to rule out Duchenne muscular dystrophy, then it's very simply including CK in other tests you are doing. And CK test, which is creatine kinase, which is an enzyme that is present in the muscles, and it will leak in the bloodstream because of that disruption of the muscle fiber that it results from the lack of dystrophin protein, as we already explained. And this is a cheap test, it's quick, it's available in all hospitals, including district general hospitals. So if you have a child with any delay at any age, CK test should be one of your main testing panel, really. And the majority of cases you will test when the child has developmental delay in any area, even if it's not mainly motor, will have a normal CK, but you will have situations where CK will come high. Now, there might be situations where you saw the child and you're strongly suspecting a muscular dystrophy and you're expecting CK might be high. There might be other situations where you did it as part of your general investigations because the child is delayed, and then you get surprised that the CK is high. And this is why it's good to have a little bit of a frame of what you're going to do in those two situations. If you're strongly suspecting that CK might be high and you might be going down the route of investigating for a muscle weakness disorder, muscular dystrophy, then you might want to give the parents a little bit of a warning that you might be expecting that, and have some agreement of how you're going to communicate the results to them, because the CK test comes back on the same day or the next day in majority of hospitals, and how you're going to communicate that to them. Bearing in mind, the moment you say creatine kinase to parents and they Google it, that's the first thing they will come across, which is Duchenne muscular dystrophy, and all the information on the internet gives them lots of alarm. So if you're strongly suspecting it, you might want to give them a bit of warning that you're expecting that. And it would be a good idea to take a DNA sample at the same time you're doing testing. Now, if you're suspecting muscular dystrophy, you'll take a DNA sample and you'll warn them that you will be testing the dystrophin gene if the CK is high. If you're not and you're doing general developmental investigations, you anyway might want to take DNA sample because you tend to do microarray tests for a child with developmental delay. So it is a good idea for anybody with delay to take a DNA sample at the time, warning them you might need further genetic testing. And then have a bit of an idea from your genetic lab of how long the results come. We'll talk about testing of the dystrophin gene a little bit later, but you initially will be looking for deletions or duplications, which will look at about 70% of your gene mutations. That's a test called MLPA, and if that's normal and you had a high CK and you're suspecting a dystrophy, then you'll go to point mutation testing, which takes a little bit longer. So you want to have a little bit of a plan of how you're going to communicate results. We had situations where parents have been phoned with test results, and that is really not good practice. Ideally, what you want to do if you get a really high CK test, usually in Duchenne it's in the many thousands, what you want to do is have a discussion with your local neuromuscular center and do an urgent referral, saying to parents that CK is high, you're suspecting a muscular dystrophy, you're looking for the most common one, and you'll make a referral. In it, you can initiate the test for the dystrophin gene yourself, but then if the result is going to come to you first, you do need to have a planned face-to-face, thinking that that's when the results are going to be available, or have a plan with the neuromuscular clinic whether they are going to see the patient and give the results, because it can be very traumatic to give results over the phone. You do need, and if we move to the next slide, and this is what we do in the neuromuscular clinic. So I sometimes in my neuromuscular clinic will see patients already have been given the diagnosis because they had it in the local pediatric clinic, or they referred to me with high CK and I've done the testing for the gene and I give the parents results. And I usually say to them, I will not give you the results over the phone, we'll arrange an appointment, and I try to time the appointment and when I'm expecting the result to come. And usually we meet for the giving the news about the diagnosis if we have a confirmative genetic diagnosis, and give information as much as you feel the parent is ready to have information, and obviously have some written information ready as well about the condition. Now, what you ideally need to do, because if you imagine what will happen when they first get the diagnosis and they've already might have Googled a lot of things online, is that the amount of information that will go in and the amount of trauma at that first appointment is sometimes difficult. So this is the important role for a nurse specialist or a neuromuscular care advisor to follow up with the family in the next few weeks. There are differences between families of when they want that follow-up to happen. We ideally arrange a home visit to discuss more. Sometimes the parents want to come back to clinic and discuss with me in the next few weeks, and we offer that opportunity as well. We discuss referring to cardiology for a baseline heart assessment, to endocrinology for bone density scans to look at the bones, and to the genetic team for a mutation screening for mother, and also for talking about future. Physiotherapy interventions are very important from early on, and obviously the educational setting and what modifications the child need. There are in lots of countries also helpful charities and lots of information. You might want to signpost them to a lot of good places where they get measured information, because there is quite a lot available on the internet which can get families lost in it. And obviously discussing of steroids will be dependent on the child's age, but also on the readiness of the family.
Thank you very much, Zoya. What I understand is that this diagnostic journey can be very long, right? And sometimes painful for families. So maybe there are ways to go faster, and today we have more and more pilots about newborn screening. Jackie, you have first-hand experience in such pilot. Are you happy to share with us your experience?
It's very tricky when you're implementing a newborn screening program. It's very different from when you are diagnosing a child later, because the family are sitting in front of you with a perfectly healthy newborn infant, as opposed to a child that has been picked up by other healthcare professionals or by daycare or kindergarten or whoever with an actual clinical sign. So it's very, very tricky. And one of the first tests, as you said, we can do is looking at the CK levels. But unfortunately, it can be a little bit hard to determine if this baby has a high CK because they have Duchenne Muscular Dystrophy, or maybe it was a traumatic birth just on their first day of life, because anyone can have one elevated CK. If anyone went and did a CrossFit class or ran a marathon, their CK the following day would be elevated. And if you think of, birth is can be quite traumatic for some babies. And so you need to be really careful about how you interpret a CK on a baby that's only a couple of days old. So also there are other forms of muscular dystrophy that a child can have an elevated CK. So traditionally here in Australia, when newborn screening was set up, it was a biochemical screening test. So the children would have a blood spot taken, and that would be run in the laboratory, and they would be looking for biochemical markers. But as we said, CK, while it's an excellent marker for Duchenne, it's not completely diagnostic. So we have started screening in Australia some other conditions on our newborn screen, looking at the actual genetics and the molecular diagnosis. And unfortunately, it's a lot cheaper than it used to be, but it's not the cheapest test. It's a lot more expensive than doing a biochemical test. So we've integrated into a larger genomic program. However, as we've said before, there are 70% of pathogenic variants in the dystrophin gene that lead to Duchenne are duplications and deletions, and only about 30% are actual sequence variants. So that makes it a little bit more tricky than a condition such as SMA, for example. So we are about to start a pilot program in Australia. What we're going to do is look at the molecular basis of the babies for Duchenne, and we have to do looking at the copy numbers and at the sequencing as well.
So, Jackie, could genomic be a first-tier test if we have a genomic newborn screening program and CK a second-tier test to be sure that the variants that are identified are pathogenic?
That's what we're planning on doing. So watch this space, because hopefully that is our theory, and hopefully that's going to work very well. So yeah, we're about to start very soon. And so, yes, if we have this conversation again in about 6 months to a year, maybe I'll be able to be a little bit more definitive. But yes, that's exactly what we're planning to do.
And that's what we are doing in Southern Belgium also.
So there are many different pilot studies going on around the world where we're looking at exactly this. So here's just a few here, one in Taiwan, they're looking in Europe as well, and in Belgium. So there's quite a few going on. So hopefully this will become part of the mainstream for newborn screening in the future. But in Australia, as I said, we're about to start a pilot study. So what we want to do is diagnose early, because the earlier that you diagnose, the better chance you have for early intervention and surveillance. The other advantage of having early detection is for reproductive planning in the future for these families. It can be very tricky though, again, because Duchenne is an X-linked recessive condition. So you need to be very careful, because with mothers, in the time frame that you are doing newborn screening, they are at an increased risk of postnatal depression. So one of the things that we are a little bit concerned about is causing more grief to a family, and especially to a mother, because if they feel like this is their fault and they're being blamed for this, it can not have great outcomes for families. So we are going to be very careful with that, and we're going to hopefully have a lot of support from social work and psychology to hope that we can support our families through this. So also early detection, if we do identify that there are females in the family who are carriers. The other benefit of this is to implement a surveillance program for themselves, because as I'm sure you're all aware, females who are carriers are at risk of developing cardiomyopathies. So one of the things we're hoping to achieve is to have some early identifying female carriers and putting in some preventative health strategies for them. So we're hoping to start in the next 12 months. And yeah, we will see how it goes. So we're very much looking forward to it. And as you can see from the diagram here, this is how we're hoping to do it. So if we start with looking at the CK, and if it is a normal CK, then no further screening tests. And then if it is elevated, then we're going to go from there. So looking if they do not identify any pathogenic variants in the dystrophin gene, then we won't be screening any further. But if they have been identified, then the newborn screening lab in New South Wales will flag the result to the paediatrician and the neuromuscular specialist. The way that in New South Wales, how newborn screening results are given is usually by the paediatrician at the hospital where the child has born. But we have trialled it for SMA, and we're going to trial it for Duchenne, that it actually works better if the result is notified by the neuromuscular clinic and the neuromuscular specialist. So then the infant and the family come to see us at the hospital, and we try and do this within 24 hours because, you know, as soon as you make that phone call, they start Googling. And as you said, Zoya, they can see some pretty horrific things when they Google. And so we try and see them as quickly as we possibly can. Okay, so when we then see them in the hospital, the plan is to repeat the CK and to repeat the test that was done on the newborn screening lab, but also to collect some diagnostic bloods so that we can confirm in a NATA accredited lab. Because it's always important to remember that this is a screening test. It's not an actual diagnostic test. So that's also a very important factor to bear in mind.
So thank you very much, Jackie. And thank you, Zoya. I think that it's good to have a diagnostic, better early than late. But then we need to think about treatment, right? And that's the next step. What can we do to start? Well, there are plenty of things. Even if we don't have a cure, we have a management of Duchenne muscular dystrophy. We have teams to work together to give these kids and these families the best future we can. So we have already discussed a little bit about steroids, and I think that it's important to emphasize at the very first meeting that we have today treatments that works in Duchenne muscular dystrophy, that does not stop Duchenne muscular dystrophy, that does not cure Duchenne muscular dystrophy, but that brings significant benefit to the child. And obviously, physiotherapy and management, global management, how to live with Duchenne muscular dystrophy is something that we need to start discussing at day one. So we will go later in more detail about steroids, but I think it's important to explain the families first the benefit, because that's the treatment today that works the best. And then it comes with side effects. And the way personally I present the side effect is there are some side effects that we can manage quite well, in my opinion, and some for which we are not that good. We do our best, but we have to accept at one point, and we need to consider steroids as a balance, right? And this balance can change during life, and the side effects can be very different according to how long the patient has been exposed to steroids. So the benefit is definitely that steroids delay the progression of the disease, it delay the loss of ambulation, and at further step, it delay the loss of upper limb function and the decline in respiratory function and slowing the progression of cardiomyopathy. These patients live longer in a better condition. It also delay or prevents scoliosis. And since we treat these patients with steroids, we have much less patients who have to go to spinal fusion. We also know that the optimal timing of steroids initiation is not exactly known, but we know that if it's too late, it's too late. And we should probably start before the age of 5 or before the age of 5 years. There is not a huge level of evidence, but there are some. And then should we start at the age of 3 or 4? It's still unclear from the literature. And then we have several different regimens of steroids, and today it's mostly either prednisone, either deflazacort, but there is a new steroid that is just approved. It's called vamorolone, and it could potentially have less side effect, especially when it comes to bone health and to growth. And there are several ways to prescribe steroids, right? You can give it every day. You can give it 1 day on, 1 day off, 10 days on, 10 days off. Sometimes just during the weekend. It's we are pretty sure now that giving it every day is the most efficient way, but it comes with a cost, and the cost is the side effect, right? In the young kids, the first side effect is behavior, right? It can make them quite nervous. But then come other side effects, and one of them, which is probably the one for which we are the most, we have not so much action, is the delay in growth. And these kids are small, and they can suffer from a psychological perspective. To be small, for them sometimes is worse than to be weak, and we have to appreciate this as doctors and parents, because we sometimes very proud and very happy of the effect of steroids, but we need to appreciate what it really means, this balance from the child perspective and not only from our HCP perspective. Another one is certainly bone demineralization, for which we have some possibility to act on. And an important one in the future, when the kid will become a teenager, is the delayed puberty. And we should not underestimate the importance of puberty for these kids. We have treatments that are approved, but we also have trials, and we have drugs that are approved in the US or in the EU, and not on the other side of the ocean. So yeah, would you be happy to bring us into the different trials approach for Duchenne muscular dystrophy?
Will not venture into going into detail in each one of them, but just to explain the principles that trials have taken. So one approach is targeting the muscle fibrosis, necrosis, and looking at approaches that reduces that and subsequently reduce the progression of the disease. And falls under that, obviously we understand glucocorticoids work, as Laurent mentioned, but we don't know all the mechanism by which it works, but we know it works on inflammation and fibrosis in the muscle. But there are other approaches that work on that element of the disease that are either in trials or had preliminary approvals. There has been many other trials that, for example, targeting myostatin or using things like tamoxifen, and trying to see if using other drugs can have any effect. And some of these got stopped, sometimes because just the primary endpoint wasn't reached. Now, the other approach is targeting the primary. So we have a protein that is either absent or truncated because of the mutation, and targeting that protein production via approaches to different stages of the making of that protein. So this is where exon skipping, for example, comes into play, read-through therapies and gene therapies, and I'll explain a little bit more about that in the next few slides. So vamorolone is a synthetic steroidal drug that is similar to prednisolone, but differs in a couple of binding sites. So the idea is maintaining the anti-inflammatory effect of glucocorticoids, but not maintaining some of the metabolic effects responsible for the side effects. It's been approved in some countries and being appraised in some others. It's a liquid medicine that is taken once a day orally. So that might come into play in treating children as we in the near future. And then if I move on to the other side of that chart where we talked about approaches to target the protein production. And this little diagram shows the stages and where targeted therapies. So gene therapy, for example, is targeting the primary gene mutation, whereas exon skipping is where the target is the pre-messenger RNA during the splicing process and modifying how the protein production is made. And there is a couple of slides to explain those approaches. So with exon skipping, for example, if you look in the middle of this slide, if you are missing an exon that has caused out of frame deletion, as we explained earlier, the exon skipping approach uses an antisense oligonucleotide. So this is a particular RNA series that will bind to the next exon. So they have a deletion of exon 52, and you have an antisense oligonucleotide that binds and hides the exon 53. And the theory is that then that restores the reading frame of the dystrophin messenger RNA, and ideally leading to a full dystrophin protein production. So this is the approach with exon skipping. This is drugs that are delivered once weekly by IV infusions. And then the next step from that is actually gene therapy. And as we explained earlier, this is the dystrophin gene is one of the biggest genes in the body. So packaging it in a viral shell is very difficult. And the idea of microdystrophin came from the knowledge that some people may have a very large dystrophin mutation, but still have a milder phenotype because they had an intact reading frame, or a reading frame that was maintained. And that's the approach used for microdystrophin, where the reading, it's a shorter gene, but maintains the reading frame. And different companies have different programs with different with different viral vector. And some of the programs have been approved in some countries, and some more trials are coming as we go along. And this is mainly targeting, obviously, the gene itself, the gene defect. And more treatments are being looked at, approaching both sides, whether that's protein production or inflammation of the muscle. The treatments need to be safe but also effective, and the side effects need to be tolerable and manageable, and don't add any additional burden.
I think that it's a very exciting period of time, right? I mean, we have treatments, but we see many other treatments reaching patients' bedside at the clinical trial level, and some of them that are approved nowadays. Nevertheless, there are some aspects on which drugs may help, but not only drugs. And I think that one of these aspects is certainly the central nervous system involvement. We are very lucky to have with us some Goyans who could help us through this different CNS issue in these kids, and what we can potentially propose to them and to the family.
Yes, indeed. I think it's very important to also be aware that Duchenne muscular dystrophy is not only a muscular disease. Of course, the physical symptoms are very severe and very prominent. And I think in some points of the disease course, they deserve the attention they can get, but also the behavioral and cognitive aspects, the CNS aspects, are very important. And in some parts of the child development, they can be very manifest and even more burdensome than the physical impairment that the child is experiencing. Especially for the parents and especially for the surroundings, it can make development very difficult. So I really think as healthcare professionals, it's important to screen for them, because not all parents are aware that they can ask questions about it in a medical setting like a hospital. So it's important that we ask them about behavior, that we ask them about academic achievements, or about how the cognitive development is going. Not all of those aspects are very clear in the beginning, because all children are often very young when they come to us in our neuromuscular center. But when we follow them through their development, we can see that some problems are becoming more manifest, and then we can intervene, or can give them some advice how to cope with it, or how to deal with it at school, for example. So I think from the beginning, it's important to inform the parents that when they see something that is difficult to deal with, that it can be a part of normal development, as every child can have a difficult period. But it also could be a part of Duchenne muscular dystrophy, and that they can talk with you about it, how to cope with it. So if we don't give them the background of this, and if we don't give them this information, they can think that it is a problem with themselves or with their parenting skills. But also for teachers, it's important to know how to react on some behaviors. In this slide, it's very important again to know that some Duchenne muscular dystrophy patients need more repetition. They have difficulties to learn new skills. That can be learning academic skill, but it can also be social behaviors. So sometimes we really need to explain to them why we do something. Some things we really need to make things explicit. So that's very important to know. I think there are some things that we can do about it. If it's really, really difficult and really difficult behavior, we need to refer to specialized centers like child psychiatrists or child psychologists. However, in the general population, Duchenne muscular dystrophy is not very, if they know, is not a thing that the general psychiatrists know about. So it's important that you give them the relevant information so they can get the expertise, and they can integrate every aspect of the child. We see that some patients are very well helped with psychotherapy, especially cognitive behavior therapy can be helpful in some cases. And we also see that psychopharmaceutical drugs can be part of it, that it can be safe even in patients with a neuromuscular condition, and also be effective, and that they are very well helped with it. And I really think that we need to be very attentive for parents, because the burden of the CNS aspect can be very hard. And of course, it's a chronic condition, so they have to endure this through a long period of time. So self-care, and sometimes searching for possibilities to give the care for the child to someone who can help with it is very important to keep going on the long term.
This is a very important part of what we call standard of care. And standard of care has been published, and this is 3 recent papers published in Lancet Neurology. A key element of standard of care is to work as a team, right? Which we are doing today, right? To work as a team that involves the physiotherapist, the occupational therapist, the psychologist, the nutritionist, and of course all the different consultants, not only the child neurologist, but the cardiologist, the respiration team, and the orthopedists. We need to consider the patients in the center of this target, and we need to have a patient-centric approach, and to collaborate with the different specialties and with the different healthcare providers to provide with a holistic management of these patients. I think that an important part of the management is also sometimes to manage the expectations, and there's a lot of information flying around, and there is a lot of excitement, and this is good, because if there is no hope, it is quite terrible. So I think that we need to respect the hope of families and the excitement that can generate some communications, but we need to also to manage these expectations when it comes to new treatments for which sometimes families are ready to make incredible things like relocating, selling their house, or even coming to a trial. And I think that it's also very important to be clear with the families that a trial is a trial, right? And a trial is done to answer a very simple question like, does it work or not? Is it safe or not? And if we have the answer before asking the questions, then there is no way to run a trial, right? So it's a difficult balance, but it's a balance that we need to provide the family with, is to respect the hope, to work with this hope, but also to manage properly the expectations. In the management of the patients, of course, there's the evaluation. The evaluation can be done by doctors. It can also be done by physiotherapists, and more it can be done with innovative technology. And this is one of them on which I've been very involved, which is actually the use of magnetoinertial sensors, which are small watches that capture every single movement of the patients. And when you fix it on the ankle, you have every single stride. And we could show that the 5% most rapid strides of these patients constitute a very robust outcomes, which are sensitive to change. And it has been recently qualified by the European Medical Agency as a primary endpoint in Duchenne Muscular Dystrophy. So the take-home message of this first part is, one, we need to work as a team. We need to work as a team to manage these patients, and we need to work as a team first to diagnose these patients and then to propose the best management. There is no cure today, and we need to be clear about that. But there is a treatment, there are management, and the life of our patients today is very different of the life of the patients who are born 60 or 70 years ago. So we need to work with families, and we need to work with the entire team to give our patients the best future.